So thanks so much for inviting me to speak. I'm going to talk on this topic, using AI to detect dementia. What are the ethical issues? And I think this is quite relevant given some of the talks we've already heard. So I'll try and bring in some of my thoughts about things that have already been discussed as we go along. So the overview of my talk is around looking at the dementia diagnosis gap, delayed diagnosis, and then why artificial intelligence developers might focus on early detection. Then a quick overview of what is AI and current AI and what are now being called biomarker approaches for early detection of dementia. Then I want to get the paradigm of ethical screening programs onto this AI development and consider it in relation to early detection of dementia, and then make some recommendations about how dementia early detection using technology and AI can proceed ethically. I think we've heard quite a lot, haven't we, already about why early detection of dementia is really important. So a lot of my previous work has been around this diagnosis gap, particularly in primary care, of people who have dementia but don't have a formal diagnosis recorded in the healthcare system for that. And looking at that, we've found that currently diagnosis is often made at a time of crisis. For example, we heard from Rob about a high rate of falls and fractures at admissions to hospital. It's also made when the family come forward because they're struggling to cope with particular care needs. And these two situations can mean that the diagnosis occurs too late for the person with dementia to express their financial care preferences and make their own plans. So one study published in 2020 showed that an average of 3.5 years passes after a patient meets diagnostic criteria for their dementia before they get their diagnosis recorded in the healthcare system. We've also heard, and I think everybody is on board with several reasons why we might want to detect dementia earlier. So at the current time, I think we can support patients to have time to plan, express their wishes, organise their care, and understand their prognosis. We also want, of course, to enable access to disease-modifying treatments in the future when these become available. And while these are in the development phase, it may be that if we can identify dementia at an early stage, this creates opportunities for people to be recruited to clinical trials for new treatments as well. Okay, so that's why there's such a focus on early detection of dementia. So let's switch our focus now to artificial intelligence. So what is AI? So it's the simulation of human intelligence processes by machines. And it's generally underpinned by machine learning, so things like neural network models. And so this means that AI systems will ingest or take in large amounts of training data. And I'll talk to you in a minute about the sources of data for early detection of AI. Then we use these machine learning models, often neural networks, but there are other machine learning approaches, to analyze that data for correlations and patterns that exist. And then the machine learning system begins to be able to make predictions from these patterns. And so when you feed it new data, it can make a prediction about the individual that data belongs to. So in terms of early detection of dementia, there are a number of technological and AI approaches that are in development. Now, arguably the most advanced at the moment is using machine learning models or AI. These tend to be used sort of synonymously to analyze brain scan images. So a lot of patients, when they go through a memory assessment service, will have some kind of brain scan, and a lot of research cohorts do scanning of their participants' brains. So there's a lot of image data out there, MRI, PET, SPECT. Please don't ask me to explain what the different types of scanning are. That's not my field. But artificial intelligence methods for being able to distinguish a brain that has or will go on to have dementia from somebody with mild cognitive impairment or a healthy control. That's quite advanced and quite reliable and accurate. Additionally, there are becoming new ways of collecting kind of big data or lots of data on people who may be at risk of developing dementia or at the early stages of dementia. Some of these things are, for example, wearables. So is someone's gait changing? Are they more likely to be falling? How many steps they're taking? Is the pattern of their walking reducing over time? We can put sensors in people's homes to see, for example, are they waking in the night and walking around, or other changes in the way that they use the space at home. In fact, also sensors have been put in people's cars in the early stages of dementia to track any changes in the way that they drive. And we heard yesterday from Kath Sykes and Rebecca Atkinson around digital ways of collecting data from people to sort of track their progress following an MCI or a dementia diagnosis. So screening tools can be uploaded onto websites or onto smartphone and tablet apps. Often historical kind of screening tools rely on language, and increasingly games are being developed where people can play them and they don't rely on language, but they can have sort of reliable differences in how people play those games depending on whether they have dementia or not. And my field is looking at people's health records, so particularly primary care, but as we heard from Rob, we can use mental health records to look at, see if there's a signature of change over time in someone's data. Are they getting more frail, for example? So these different sources of kind of big data that can be fed into machine learning approaches have different levels of accuracy in determining if somebody has dementia or doesn't. And arguably, the highest level of accuracy is being able to combine sources of data. So multimodal data means data from different sources or in different formats, and combine them into really accurate predictive models. So that's the kind of very quick, brief picture of what AI development looks like at the moment in terms of trying to detect dementia. And let's quickly go over the ethical principles. So there's two frameworks we could use. The first that we might want to consider as AI ethics, which is actually sort of becoming quite developed now, understanding how we can develop AI in an ethical way. This tends to be underpinned by principles of transparency, explainability, interpretability. So this is kind of, can we see how the AI got to its output or its prediction? Can we understand what it favoured in terms of its inputs and what it thought was most important? And then responsibility and accountability around the issues of, well, if the AI, say, made a wrong prediction, whose responsibility was that? Who is accountable for that? Or if we integrate AI into a clinic and the AI says one thing and the clinician says another, then who gets the final say? Who's accountable then for that decision? And then issues of fairness and trustworthiness. So knowing that, there's a lot of bias, racism, other systemic, biases in the way that healthcare data might be generated. How can we trust that an AI trained on this data with systemic biases might produce trustworthy or fair outputs? So those are all really important points. But in the end, I decided to look at the framework of ethical screening programs. So this is a framework that was developed in 1968 for the World Health Organization. So they argued that screening was an approach to discover those among the apparently well who are in fact suffering from disease, which I think also fits closely this early detection paradigm. And they proposed 10 principles for evaluating whether a screening program will produce more benefit across the population than harm. So 10 principles, hard to fit on a slide. Here they are all in purple. So they range from things like that the condition sought should be an important health problem, which I think we all agree holds true for dementia. But then that there really should be an accepted treatment that changes the course of the disease for patients who have that disease. Facilities for diagnosis and treatment should be available. And then 4 and 7 are around that if we can detect something early, that we really understand closely how that will develop. And then that the tests are suitable and acceptable. We know who we're going to treat as patients, and then more things about the sort of cost of case finding across society down in 9 and 10. So let's just consider some of these directly relating to early dementia detection. The first problem I think we have here is there's no accepted treatment at the moment which changes the course of the outcome of the disease, which leads us to ask, so why are we detecting it early? We hope, of course, we think that there's a benefit to patients, but that benefit may only be for those who want to know about their diagnosis. Can we really extrapolate that to be a benefit in patients who don't particularly want to know? And people who want a diagnosis can come forward already, which leads us to the issue that at the moment, diagnosis services are already stretched and post-diagnosis support is patchy. So I think if we're going to look at population implementation of early dementia detection, we do need a full financial and workforce plan to cope with the increasing number of people seeking confirmatory diagnoses and support. So as we heard from Rebecca yesterday, why aim for a timely diagnosis if there's nothing on offer following diagnosis? And as we have from Rob now, which service or whose job is it to support the people that come through? Who's going to take ownership of that new cohort of people? The other issue we've got is that the future trajectory of any one individual's cognition from, say, mild impairment or early disease through to dementia we can't accurately predict it at the moment. We don't have good models that say this person with MCI will have dementia in 1 year or 2 years, and this person won't. So getting a very early diagnosis may not be helpful until this can be predicted accurately. And then I think this is a really important conversation. Digitally delivered early detection is likely to exacerbate health inequalities because access to digital devices and technology is not equal across everyone in the population. And this kind of technology is likely to be offered direct to consumer, paid for by individuals rather than state-funded health systems. Also, we know that different groups, so different cultural groups or ethnic backgrounds, consider dementia differently and are more or less likely to take up screening. I think there's two more important questions that I want to ask, certainly as an epidemiologist. Are these techniques accurate enough? So I said the most advanced techniques are the brain scan AI models, and they do have accuracies of over 95%. But the passive techniques, where the sensors are in homes or on wearables, have an 80 to 90% accuracy. And the lower the prevalence of the condition in the screen population, so the more broadly you spread out a screening program, the higher the number of false positives. That is people who flag as positive for dementia but actually don't have it. And that is a situation that could easily lead to harm. The other issue we've got is that screening is not necessarily acceptable to the whole population. There will be a patchy uptake. So one primary care-led US dementia screening trial, of those who were eligible to attend, 38 didn't come in to be screened. And of those who did come in and screened positive for dementia, 66% of them refused further investigation to determine their actual diagnosis. And we know that especially GPs may reject dementia screening when they feel they don't have anything to offer their patients as a result. So very quickly, I think we need to get these things in place for AI dementia detection programs to be ethical. I think we need treatments available which change the course of the disease and which are more effective when started earlier for patients. I think we need to be able to accurately determine how likely someone is to progress to dementia in the prodromal, like the early or the MCI phase. I think we need to make sure that our early detection method is highly accurate, but doesn't require a very invasive bunch of scans and tests, and it's cost effective. And I think the very key thing is that we look to resource the health service pathway that would support this group of people coming through from early detection methods that they have maybe bought themselves or initiated themselves. And finally, for the ethics to really hold, we need to make sure the decision to undertake early detection of dementia is voluntary, free of coercion and confidential. The potential of harm for each patient to be assessed because of this risk of false positives having a very negative psychological effect. And deployment could be monitored for fairness, so that implementation does not contribute to health inequalities or reducing bias. That's the end of my presentation. This, you can see a really full version of this online. I'll put the link in the chat. We've just had this published in February. And you can get in touch with me here on my email. And I need to disclose a commercial relationship as working for a consultant for a company called Acribia Health. So I'll put that slide back on and finish. Thank you.